Thank you very much. Thanks for having me, and thanks for being here. So why are we still talking about smoking? Why are we still worrying about it? I mean, after all, we've known for over 50 years that it's bad for you. But still, many of us don't realize that smoking is the primary preventable risk factor for early mortality worldwide. So there's still a lot to do. And this is what I would like to share with you, some of our experiences in doing research in this field and in trying to influence policy and practice. So let's start with the why. If a mom smokes during pregnancy, and this is relatively frequent in high-income countries at about 1 in 10 pregnancies, this increases her risk of a baby having a preterm baby, having a baby with a low birth weight, having a baby with congenital anomalies, and having a baby that dies during or shortly after pregnancy. And these are all, I mean, you can see the relative increases, but these are all a bit abstract, right? This is a picture of 60 babies, 60 lives. This is the number of babies that dies every year in the Netherlands only due to maternal smoking during pregnancy. So this makes it a bit more close, right? But it doesn't just stop after pregnancy. Because if children are exposed to smoke by their parents, for example, and this is still current in about 40 to 50% of all children worldwide, this increases the risk of sudden infant death, of having severe asthma attacks, having lower respiratory infections, meningococcal disease, and moreover, if children are exposed to tobacco smoke during pregnancy or early childhood, they have a higher risk of becoming smokers themselves. And these are the ones raising the next generation. And in this way, smoking and its adverse health consequences can just remain in society unless we adequately address this. And you can argue, based on the Convention of the Rights of the Child and the Framework Convention on Tobacco Control, that all children have a right to grow up in a smoke-free environment. And this FCTC is quite interesting. The FCTC was the first international public health treaty and is now ratified by almost any country in the world. And it tries to address the current smoking issue in the world. And based on this FCTC, the World Health Organization came up with 6 sets of tobacco control measures that all countries should be implementing to address the smoking epidemic. And for this talk, I'd like to focus on one of them, which we thought was likely to also benefit children, namely implementing laws that prohibit smoking in public buildings and workplaces. So this was our first endeavor in this topic, and we tried to pull together data from all the studies that had been done in the world, looking at the association between smoke-free legislation and childhood outcomes. There were 11 studies at the time, and when we combined them in meta-analysis, we were able to show that there was a reduction in the number of babies being born preterm and in the number of children having to go into hospital for severe asthma exacerbations, simply by implementing a law prohibiting smoking in public places and workplaces. However, we also noted that there were still a few knowledge gaps. There were no studies looking at perinatal mortality as an outcome. There were no studies looking at respiratory infections. And as you can see from the map, there were no studies looking at the impact of smoke-free legislation on child health in low and middle-income countries. And this is important because the low and middle-income countries are now the ones experiencing the most severe burden of tobacco-related disease. So then in follow-up studies, we tried to address some of these knowledge gaps. And England in 2007 was one of the first countries in the world to introduce a highly comprehensive smoke-free law, making all public places and all workplaces smoke-free from one day to the other. And we did a study evaluating the impact of this smoke-free law on respiratory infection admissions among children. This was a study on data of over 1.5 million hospital admissions for respiratory infections. And we were able to show, if you adjusted for other confounding factors, that introduction of the smoke-free law was associated with a reduction of 11,000 hospital admissions for severe respiratory infections among children. In another study of the same law, we noted that the introduction of this law was associated with a reduction of 350 perinatal deaths in the country every year. Again, showing that there's huge impact of simply implementing a policy like that. But there's also less good examples, such as the Netherlands. So the WHO says that countries should be implementing a smoke-free law all at the same time and in a very comprehensive manner. The Dutch government thought otherwise and implemented smoke-free workplaces first, and then 4 years later they introduced a smoke-free hospitality law covering hotels and bars and restaurants. But also, despite WHO recommendations, they allowed smoking rooms, which are known to not be as effective as a comprehensive smoke-free law. And a year after the law already, there was the first exception made. So the small bars were no longer had to comply with the law. But then half a year later, they did have to comply with the law. Another half a year later, the ban was resuspended in the small bars. Well, you can see from the reactions that this is also what the public perceives, right? You introduce a law, you say this is important, we need to protect public health, and then you say, well, it's probably not that important. Oh, it is important. Oh, it might not be that important. So this is also what the public perceives, and because of that, the compliance with the Dutch smoke-free law in the first few years, at least, was very poor. So I told you about the English study, and we then did a similar study in the Netherlands using data from over 2 million birds, and the English data were over 10 million birds. Well, here you see the compliance figures. 1 year after the ban was introduced, smoking in bars was seen in only 2% of bars in England, and over a third of all bars in the Netherlands. And whereas we and others showed that there was a huge impact on perinatal outcomes of this law in England, there was a bit of an impact in the Netherlands, but it was much smaller. And I realized that these are only 2 studies that I'm comparing, but it provides food for thought regarding whether implementation of this law and enforcement is important. Well, in the meantime, others had also been doing studies in this field, so we thought it would be good to update our meta-analysis and systematic review on this topic. And as you can see, many more studies had been published in the meantime. And we now had data from these studies of over 50 million births and 2.5 million hospital admissions. Well, here's the results for preterm birth. So these are 10 studies performed in different countries that all looked at the association between the implementation of smoke-free legislation and preterm birth as an outcome, and all adjusted for confounding factors, and we only selected the strongest methodological studies. And pulling them together shows that implementation of smoke-free legislation is associated with a 4% reduction in the number of babies being born preterm. And not only that, there were also important reductions in children having to go into hospital for severe asthma and children having to go into hospital for lower respiratory tract infections. And importantly, we also were able to show that the more comprehensive laws had a higher impact. But still, no data from lower middle income countries. There's the one dot from China there, and that's Hong Kong. So not particularly low income. So this was the next thing that we wanted to address, and this is done by a study led by people in Imperial College, and we decided to focus on Brazil for various reasons, because Brazil is a very large country. It's been very effective in its tobacco control policies, as you can see in this graph, getting male and female smoking down very well over a long time period. But also, the interesting bit is that from a quasi-experimental evaluation point, it's an ideal setting. because many municipalities, regions, cities already introduced local smoke-free laws until at some point they were brought onto regional level, and at a later point there was a national smoke-free law. Well, some of you who may be aware of quasi-experimental research evaluations will realize that this is a nice situation to do a policy evaluation. And here's the main figure from that paper. So what this shows is the blue line is the change in infant mortality, which was our main outcome, in Brazil over time. And you can see that there's a reduction, and what the red dotted line shows is what our model estimates that what would have happened to the infant mortality had no smoke-free legislation been implemented. And the difference between these lines is 15,000 infant deaths. So these data suggest that over this time period, 15,000 babies' lives have been saved by implementing smoke-free legislation. You may notice that there's also a green line. This is the line that suggests what could have happened had all smoke-free laws that were introduced been comprehensive. And this could have saved another 10,000 lives. So what this shows is that also in the middle-income countries, smoke-free laws can have a benefit to child health, and that it's important that if you introduce smoke-free laws, that they are comprehensive and not partial. So where are we now in the world? I've said that almost any country has ratified the FCTC, but only 22% of the world's population is currently covered by smoke-free laws. So we are trying to find ways in which we can translate the evidence that we now have to countries which have yet to implement such laws. And I won't go into detail, but we're currently developing a microsimulation model that can use all the data that we have from across the world to make these calculations for other countries. While these countries are still waiting to implement their smoke-free laws, other countries such as England are thinking about new ways to protect children. In 2015, England was one of the first countries in the world to introduce a law prohibiting smoking in a car when children are present. And this makes sense because the levels of toxic chemicals in a car can easily exceed those seen in very smoky bars. So children are exposed to these high levels. And our evaluation of this law was published last weekend in the Lancet Public Health. And we used data from the Health Survey for England, which is a nationally representative data set of children aged under 16 years. There were over 20,000 children in the data set. And we looked at tobacco smoke exposure, salivary cotinine levels, so measuring whether these children were actually exposed to tobacco, and also respiratory outcomes. I'm only showing one figure, which is the figure of the time trend in self-reported tobacco smoke exposure in cars, which is one of the most important outcomes. Well, the good news is that over the time period there was a reduction in tobacco smoke exposure in cars among children. This is probably due to all the tobacco control policies that have been implemented in England. The sad thing is that when the regulation was implemented, there was no additional change. So we are still slowly decreasing, but there was no additional effect of this law, which still makes sense. And 1 in 20 children still remains exposed. So if this law makes sense, then why doesn't it seem to do what we hope it would do? Well, there's various reasons for that, but one that we think needs addressing is enforcement. Even when the law was introduced, already police officers said, well, we probably won't be implementing or we probably won't be enforcing this law because we already have too little money to cover our services. And so people already knew that there was unlikely to be enforcement. And in an evaluation of the first 7 months of this law, only 1 fine had been issued in the whole of England and Wales. So we think that enforcement is the thing to focus on for increasing the effectiveness of this law. So the nice thing about doing this policy-relevant research is that it can also provide input to policy. So this was a consultation that was recently closed just the day after our work was published, and we provided input from our research work in this consultation, which will allow the UK government to plan ahead their future tobacco control policies. And similarly, I've been invited to advise the National State Secretary for Health in the Netherlands for developing the National Prevention Plan, which is tackling tobacco, alcohol and obesity as key factors of disease in the Netherlands. So more practical things that you can do. In the Netherlands, we now, since about 2 to 3 years, have a collaboration between all professional organizations being involved in child health and care around pregnancy. And also the government is involved and funding agencies are involved. And together we try to tackle the issue of smoke exposure during pregnancy and childhood. And we do this by informing policy and practice. We publish articles in popular media such as magazines about being pregnant, but also professional media to update our own professional groups. We've published a national guideline on smoking cessation for pregnant women, and we've developed an e-learning to help professionals learn about motivational interviewing to address the issue of smoking among parents. And this motivational interviewing e-learning has now been completed by over 2,000 professionals in the Netherlands. And what's particularly good in the Netherlands in the recent years is this concept, focusing on the smoke-free generation. So it's always hard to discuss actual smoking because some people might argue that smoking is your own decision, but no one, or almost no one, wants their own kids to become smokers. So this is a very strong concept to work on tobacco control in a country. So what else can you do? Well, first of all, and quite obviously, providing a good example is important. But also realize that there are many opportunities during care of a baby, an unborn baby, or a child, to talk to parents and grandparents about smoking and smoke exposure. Tell them about the risks and also know where to go for help. So realize yourself, do you know in your environment if you get parents who smoke and they want to stop, where to send them to? And also I urge you to have a look at your own hospital. This, until recently, was the first thing that you came across when you entered our hospital grounds, a smoking facility. And we've done an evaluation of our hospital environment. Here is the Erasmus Medical Center on the bottom, and there's a high school on the other side of the road and a University of Applied Sciences at the other side. And we've counted smokers during working hours and weekdays to see where are they, how many are there. And we counted over 4,500 smokers every day during working hours in this hospital and school environment. And the vast majority of smokers were concentrated around the main entrances, exposing others to not only the exhaled fumes, but also the image of smoking being normal. And this is what kids see when they enter our hospital grounds and the schools. And together with the schools, we approached the municipal government, and I'm happy to say that we now have the first smoke-free area in Rotterdam. So this is now formally designated the smoke-free area, and this was launched 3 weeks ago. And we're now doing rounds every day to talk to smokers about why they might still be smoking in this area, and tell them where they can go if they want to smoke, and tell them that well, the best thing is to stop, obviously. So this is a thing that you can also do in your own hospital. And besides telling people where they can or cannot smoke, we now also have a program for patients, and we also have a program for our own employees. So employees can get a free course to stop smoking in group sessions, and we've also we're doing an evaluation to see whether financial incentives might be additionally helpful in making employees stop smoking. So the final slide, before I come to the conclusion, is taking you back to your own environment, NICU, and realizing that even our very preterm babies aren't safe from smoke. This is a proof of concept study from the US, where they evaluated 5 preterm babies who had never left the hospital and whose parents were smokers. And they found tobacco smoke constituents on the skin of these babies, on the incubator, on the chair where the parents were sitting with their babies, up until the urine of these babies. And this also has implications for our workforce, who might be smoking during their breaks. So even if you smoke outside, these children may not be safe, and it's important that we do more research on what the health implication of this might be. So in conclusion, most children are not able to protect themselves against tobacco smoke, and they need us. They need tobacco control policies, which I think I've shown have substantial benefits to improve perinatal and child health. They need us to advocate for them so that we can accelerate policy making in this field. And we ourselves need to be and continue to be talking to parents about the risks of smoking and know where to send them to offer help. And I urge you to think about how smoke-free your hospital and your own NICU really is. And I'd like to end by, now that I'm back in Maastricht, thank particularly Luc Zimmerman and Onno van Schaik, who were my mentors in my first steps here in Maastricht, and Professor Aziz Sheikh, who has helped make the next steps in my career from Edinburgh. And I also like to acknowledge the funders that have funded us in doing some of this research, and I'm happy to answer any questions.